Welcome everyone to this edition of the Precision Nanosystems Tea Time webinar series. Thank you so much for joining. Today we have Professor Michael Heuser from Hannover Medical School, who will be discussing lipid nanoparticles and siRNA formulations for the treatment of leukemia. Just to give you a quick update on the Precision Nanosystems team that is available for your local support, we have myself, AJ, supported by Richard Broadhead, and we're based out of the UK. And in Germany, we have Jürgen and Martin. So if at any time you do need any help and support, feel free to contact us directly. So please do enjoy the webinar, and I'll hand it over now to Professor Heuser. Thanks very much.
Yeah, thank you, AJ. Welcome, everyone. Thank you for joining. And I'm happy to discuss with you our data on lipid nanoparticle siRNA formulations for the treatment of leukemia. I'm based here in Hanover in Germany, and currently we are enjoying a lot of snow. So let me give you a short introduction to acute myeloid leukemia. This is the most frequent acute leukemia in the adult population. It's characterized by infections, bleeding, and fatigue. It's a rather rare disease, 19,000 cases in the whole of EU, but 3,000 cases in Germany. And you can see here in the patients 60 years or older that the survival is still very dismal, and the progress over the last couple of decades is not very good. So the treatment standard since 1978 is still polychemotherapy, with some additions in the last few years. The pathophysiology has been quite well characterized so far, with enhanced self-renewal of the stem cells, with a block of differentiation and increase and a block in apoptosis. And this leads to the conversion of a normal bone marrow with differentiated cells to a bone marrow full of leukemic blasts. And the genetic aberrations that are found and are causing this cause this disease are characterized and are shown here. And I summarized key fusion genes that I will talk about today here in the middle. And of course, you know the most important role model for fusion genes in oncogenesis is the BCR-ABI translocation in chronic myeloid leukemia. There's a translocation in AML patients that is quite rare, the NUP98 NSD1 translocation. And in acute lymphoblastic leukemia, there's a translocation of the TCF3 gene with the PBX1 gene. And we use those to study the effect of LNP-siRNA formulations. We started off with a vision of personalized nanomedicine, where we take the cells from the patient, sequence the patient, and identify aberrations that we can target with siRNA. We design the siRNA and validate it, package them in nanoparticle formulations, and treat the patient. The patient relapses and the disease relapses, we can repeat this process and again target the new aberration that led to this relapse. And to start with a proof of concept for this, we use the BCR-ABI model, the CML model, that is well characterized and well known that this disease essentially depends on this fusion gene. And the idea here is that we design an siRNA that targets both partners of this fusion. On the one hand, the BCR gene, and on the other hand, the ABL gene, so that the siRNA is really specific to the fusion oncogene and doesn't target other genes, has minimal off-target effects. So first of all, we wanted to show that this model and our siRNA that we selected really works. And a good model for this are the K562 leukemic cells that are driven by BCR-ABI. We then designed a lentiviral vector either with an anti-BCR-ABI shRNA or a control shRNA, transduced these cells and injected them subcutaneously. And you can see here the cell proliferation in vitro of these K562 cells, and the control cells proliferate quite well, whereas the anti-BCR-ABI shRNA cells have a reduced proliferation. And also when we inject these cells in vivo, in the flanks of these mice, the tumor volume increases much slower if we have treated and injected cells with the anti-BCR-ABI shRNA. So essentially, the shRNA works also what we expect. Now, we of course want to reproduce this with a treatment, and for this, I wanted to package RNA, the siRNA, with lipids. And here we use the D-lin MC3 DMA lipids together with ethanol and 1.5% PEG, so polyethylene glycol. And through the staggered herringbone mixing system here from the nanoassembler, we could reproducibly generate our nanoparticles and package these. The packaging efficiency was above 90% in most of our formulations, and the size was reproducibly at a median size of 55 nanometers. So now we also labeled these nanoparticles with a dye, so a red fluorochrome, so that we could visualize them in FACS analysis. And you can see here the K562 cells untreated and then treated. And you can see here that the LNP treatment gave a strong red signal so that all the cells were positive. And when we used these control siRNAs packaged in LNPs or the anti-BCR-ABI siRNAs, we got very different outcomes depending on the concentration that we used. And here we see the viability of K562 cells, and the cells die when we treat them with 0.5 or higher concentrations of this LNP mix. So now we also wanted to know, of course, whether this is taken up, and we checked by confocal microscopy where it is taken up, and we see most of this of these nanoparticles here in the cytoplasm of the cells. This is overlaid with our K562 cells that were transduced with a green vector, so a GFP vector. And we also wanted to check the kinetics of the uptake. And this is here with different doses, was tested with different doses that you can see here. And the lowest dose is declining from day 3 onwards. And what you can also see is that 1 microgram, 2 and 4 microgram per milliliter LNP-siRNA really remains at a high, or in essentially all the cells, up to 7 days. So it's a long uptake and a stable kinetic. This also translates to a durable effect in vitro. If we treat these cells, here you can see the viability of the cells. After 2 days, the viability is still quite high if we treat with LNP-siRNAs, but then the cells essentially die. And with a lower concentration, some cells grow back at day 15. If you do a nucleofaction with the same amount of siRNA, the cells have some reduced viability on day 5, but then quickly grow back. So really the durability here was better than with nucleofaction. We also confirmed the knockdown on the protein level. You can see here the treatment with 4 microgram and 1 microgram, and with BCR-ABI, anti-BCR-ABI siRNA, and the protein here essentially is gone. We were also interested in by which method these, by which pathway and which receptor these nanoparticles are taken up into the cell, and therefore had here the untreated control, then the nanoparticles without inhibitor, and then with 3 different inhibitors, which we use to treat the cells before we added the nanoparticles. And Philippin-3 is an inhibitor of the caveolin-mediated endocytosis. It didn't have a major effect, but the inhibitors of the clathrin-mediated endocytosis had a strong effect on uptake and could inhibit uptake actually of these nanoparticles. So they are taken up by clathrin-mediated endocytosis. Now the next step was the in vivo uptake. And you know that mostly the nanoparticles are used to target the liver, and most of the nanoparticles are taken up in the liver. But of course, treating the liver is not enough for leukemia, because we need nanoparticles in all parts of the body, because leukemic cells are everywhere, and especially in the bone marrow. So here we had the setup where we injected K562 cells intravenously into NSG mice. So these are immunodeficient mice that can accept human cells. And then we treated at 0, 8, and 24 hours with our nanoparticles. And these were given here at different routes and different concentrations. One mode was 1 milligram per kg intravenously. And the yellow bars are 5 milligram per kg intravenously or 5 milligram per kg intraperitoneal. And in peripheral blood, most of the cells were positive with a 5 milligram concentration. In bone marrow, almost all cells were positive, either by IV or intraperitoneal injection, also spleen, the liver, and the myelosarcoma tissue. So the K562 cells were positive. We had some lower uptake with the lower dose of 1 milligram per kg. But this was a very important step, showing that the nanoparticles actually go beyond the liver. And what we found was that actually this loading dose of 3 repeated injections at 0, 8, and 24 hours was important to overcome the liver and go beyond in these other tissues. Then we looked at the pharmacokinetics and the pharmacodynamic, and used here nanoparticles with a control shRNA against a gene that isn't harmful if it's knocked down. That's the AHA1 gene. And here we loaded for 3 days at 0, 1, and 2 days, and then had a break and injected again every 3 days, starting from day 14. You can see here that most of the peripheral blood cells remained positive for up to 10 days. On day 14, the percentage of positive cells dropped after these 3 injections, shown in the red arrows. And then we treated again, and again, most of the cells in peripheral blood were positive. The mouse weight stayed constant over time, independent which siRNA we used, or whether they were not treated, or whether they were treated with LNP siRNA formulations, showing that it's overall well tolerated. Then we also looked at the white blood cell count and the platelet count, and between a control and LNP siRNA treatment, we didn't see a difference over this whole period. Also for hemoglobin, there was no major difference. And very importantly, serum chemistry for the different organs, like creatinine, also liver enzymes, and others were the same between the LNPs and between control. So then we wanted to see an initial sign of activity by treating mice that were injected with this K562 cells. These cells, when we inject them in the tail vein, they usually get stuck and form a myelosarcoma somewhere here in this region of the mouse. And this is before we started the control LNP-siRNA treatment. And this group is the anti-BCR-ABL siRNA treatment. You can see that the luminescence increases here, whereas it stayed the same or decreased after several injections in these mice, and this is summarized here. So a similar increase, but between the injection 4 and 10, a decrease when we treat with anti-BCR-ABL siRNA. So this was our first hint that this actually is active in vivo. Now, let me turn to the AML model. This is a fusion gene characterized here by NUP98 and NSD1 that are fused together. NSD1 is one of the most frequent NUP98 fusion partners. It has a poor prognostic subgroup in the pediatric AML cohort, and these patients show poor response to conventional therapies and frequently relapse. We had a patient with this translocation, and we used these patient cells in an NSG mouse, established model. Luckily, these cells grew and could be retransplanted in secondary mice and actually in many more mouse generations. We confirmed that the fusion is present in these cells where NUP98 and NSD1 is fused. And then we treated these mice. First, we let them engraft for 3 weeks. Then we treated them with the first cycle, gave them a break for 2 weeks, and then treated them for another 3 weeks. The dose was 2.5 milligram per kg. We injected intraperitoneal because we saw that intraperitoneal and IV gave the same uptake. And IP injection for so many times and multiple times is much easier. And the treatment schedule was day 1 to 3 as a loading dose, and then every 3 days. We first observed that after 3 weeks of treatment, all the cells in peripheral blood were saturated with nanoparticles in both the control cohort and the NUP98 NSD1 cohort. After 5 weeks, we saw a lower engraftment of human cells, so of the leukemic cells in peripheral blood, so 5 versus 15%. And after 8 weeks, there was still a difference of between 90% and here 55% between the two groups. And then we looked at the survival as shown here, and the control group died at a median of around 80 days. And here we saw a significant prolongation of these mice, and this was just a single agent treatment, right? And of course, the next question is, can this be combined with conventional treatments that we give to AML patients? Yeah, then we move to the other entity, the acute lymphoblastic leukemia. And there we had a patient-derived xenograft model that is characterized by this TCF3-PBX1 translocation. Here, chromosome 1 and 19 is fused. It occurs in 5 to 10% of both adult and pediatric ALL patients. 10% of the patients experience a relapse with dismal prognosis. And we could use this model that has been published in 2015. So here I again show you the validation. First of all, we validated the siRNA, showing that various concentrations of the LNP siRNA concentration can knock down the target. So these are mRNA levels, and the concentration of 1 and 0.5 microgram per milliliter targeting siRNA can really delete the protein so that it's not detectable anymore. We had a cell line that expressed this fusion gene and therefore could show the in vitro effect. Here, the growth is strongly reduced and the viability goes down. We see an increase of apoptosis when we use the targeting siRNA. And in vivo, when we use these cells and we use this model and use our LNP and siRNA formulations, we first looked at the CD45 positive engraftment in peripheral blood. This marks human cells, and the only human cells that are present in this mouse are the leukemic cells. And on day 26, we saw a reduction in engraftment, and especially on day 33, showing that the engraftment and proliferation of these cells is reduced. And again, we saw here significant and relevant survival benefit in the mice that were treated with the targeting siRNA directed against the TCF3 PBX1 fusion gene. And here to complete this, we could also show that the target is knocked down in the spleen cells. As you can see here, 40%. Could be better, of course, but we can prove that our target is reduced in vivo. Yeah, with this, I want to summarize. siRNA can be efficiently and reproducibly packaged in D-Lin MC3 DMA LNPs. Our LNP-siRNA formulations are efficiently delivered in human cells in vitro and in vivo. A systemic delivery of LNP-siRNAs to human leukemic cells proves that in vivo delivery beyond the liver is possible and effective. The repeated dosing in normal mice was well tolerated, and our approach, where we combined untargeted delivery with leukemia-specific targeting, proved effective, and we achieved with this a high efficacy, and hope that we now can build on this and move forward with combination treatments and also towards the clinic. With this, I want to thank my collaborators and my co-workers, and especially Nidhi Jutsana, did a large part of this, and Sagrajit Mohanty did the NAP98 NSD1 study. Also, Fiorella is now working on this, and other members of the lab, of our collaborators, and of our funders. And thank you very much for your attention.
Yeah, thank you. Thanks very much. So we're now at the top of the hour. So all that remains for me to say as well is thank you once again, Professor Heuser. That was a very interesting, very engaging and encouraging presentation. So thank you very much for joining us today. And we will, of course, be having another Tea Time webinar in a month's time on March the 10th. And we will be announcing speaker details soon. And we look forward to joining you all then. Thank you very much.
Thank you.